Hello, welcome, and good afternoon. I'd like to thank you all for attending our session today on rapid diagnostics. A couple of things as we get going. My name is Ken Alexander. I'm Chief of Pediatric Infectious Diseases at Nemours Children's Hospital in Orlando. And so I'm really pleased to be here because although I'm not a family practice doc, I talk to a lot of you guys on the phone. And so I have a great appreciation of what you do for kids and for their families. This is an interactive event. And so what we want to do is have fun. So there's three rules. Number one, we're all colleagues, we're all friends, and so this is going to be a discussion. Two, we're doing case management discussion. There are no wrong answers here. So as we bring the audience in, as you guys express your opinions, there's no right or wrong here. We just want to work together to see how we proceed on this. The third thing is, under no conditions should the program get in the way of more lunch. So if you're hungry, you need more chips, some coffee, whatever, get up. Again, this should have the feeling more of a dinner with family than some sort of fancy educational program. So we want you to use your own technology, pull out your phone, get logged in, join, because we're going to have a lot of polling questions. Use your own device and we'll go from there. So this is the title of the program, Piecing Together the Multiplex Puzzle. We're going to talk about office diagnostics. Again, my name is Ken Alexander. I do infectious diseases. With us, I have two colleagues. First of all, Abby Olululati. Abby is a real card-carrying family practice physician. She practices down in San Diego. And along with Abby, I have Dr. Amy Lieber. Amy's our microbiology expert. So what we're bringing in here is a lot of different perspectives. But the key here is we want this discussion to be useful. Right? So we want this to be about real-world experiences. We don't want to talk about assays that people don't use. We don't want to talk about clinical situations that people don't find themselves in. So that's the goal. We want to make this all useful. So here are the goals of the discussion today. Again, we're going to talk about the different kinds of assays that are available to us, what you may or may not be using in your office and what you may wish to consider, how to use these assays when managing upper respiratory infections, and finally, applying what we learn from these assays to microbial stewardship and patient management decisions. So again, log in with your technology. You can scan the screen. There should be some things on the paperwork you've got in front of you as well to get you logged in. So the first thing we're going to do is a confidence question. So this will be just to make sure you got the whole system up and working. We'll get you logged in here. So how confident do you feel right now in applying principles of antimicrobial stewardship when managing upper respiratory infections in the outpatient setting? I want you to rate it from 1, feeling not very confident, to 5, very confident. Go. Okay, so that's a pretty impressive bell curve. And that's pretty much where we think people should fit, right? That most of us are feeling good about what we do, but we want to increase our confidence, and so we can go from there. So let's move on to the next slide here. Again, what we're going to talk about, let me just back up one here. So a little bit of overviews of respiratory infections. And if there's any group of doctors that I can't tell anything about a respiratory infection, it's you guys, right? You guys know more about respiratory infections than probably any other specialty because that's what you see. These are the most common things in urgent care and primary care. The good news is they're self-limiting, but patients don't always feel that way. Right? Patients come in feeling like the world is about to come to an end because they can't breathe through their nose. We know that the vast majority of these things are viral, but one of the challenges we have is finding that one problem case where there's something more seriously going on embedded in all the viral crud that we see. and deciding when are antibiotics the right thing for us to do. And so what leads us to the decision to prescribe antibiotics? The problem we have, of course, and these are just some of the most common respiratory infections that we see, is that they all pretty much look alike, right? It's the purist among us that wants to say, well, this is RSV versus COVID, and here's how I can distinguish the two. And of course, there are differences that occur with all these things, but by and large, there's nothing there that I'd bet more than a cup of coffee on, right? The challenge that we have is differentiating between these things, and more we need to, because in many cases, if you look at influenza, if you look at COVID, there are things we can do. If you look at RSV, there are interventions that we can do to prevent transmission, perhaps prevent exposure of the elderly, that kind of thing. So the onus is upon us to actually make a distinction sometimes, because we want to treat with a neuraminidase inhibitor or one of the new nuclease inhibitors, something like that for flu, or we'll start a drug for COVID-19. But again, the problem is that looking at these things clinically, they're very, very hard to distinguish. And that's where you and I need a rapid test that can help us sort out, is this COVID so that I can consider starting Paxlovid? Is this influenza so I can look at starting a neuraminidase inhibitor? What should I be doing here? So this is a list of kind of the common things that we see, right? This is no surprise to you. But the thing that I want to sort of bring to your attention is that, you know, if you look at the whole list here, especially on the right side of the slide there, you've got bacterial infections, and what we're left with is, does this patient have sinusitis? Is this a patient with bronchitis? Now, speaking as an ID guy, sinusitis and bronchitis are probably the most difficult diagnoses to make accurately, right? They're hard to do, and every patient's convinced they have both of them, right? And so how do we make these diagnoses accurately? And again, this is where molecular testing can help you and me. The other thing, of course, is that we've seen a change in seasonality. You know, it used to be pretty predictable when these things showed up, and then COVID hit, and all of a sudden we're seeing RSV and influenza in the summer. We're seeing enteroviruses all year round. The whole thing has sort of gone tipsy-turvy, but it seems to be getting a little bit back to normal. We're starting to have more seasonal RSV again. We're seeing influenza again, kind of January, February, as the kids, you know, get back to school and go from there. So there is an evolving seasonality. It seems to be coming back, although COVID, well, it's just had its autumn spike. We've all seen a lot of COVID activity over the last couple of weeks, and hopefully that's going to settle down so it's not quite so crazy. So another question for you. According to the CDC, okay, about how many million antibiotic prescriptions are dispensed a year in the United States? So hazard a guess here. So a good rule of thumb when somebody asks you a question like this is they're trying to make a point, pick the biggest number, right? It's like always pick C, or in this case D, okay? So the answer is 236 million, right? That's a lot of antibiotics. Now, having said that, I'm not here to beat up on anybody about antibiotic prescription for two reasons. Number one, the very fact that you're here tells me that you are among the most judicious in the group. Secondly, if you travel internationally, you realize that we as American healthcare providers do a pretty darn good job. And that if you travel to South Asia, to East Asia, to many other places in the world, right, antibiotics are passed out without prescriptions, and you see a lot of really, really crazy antibiotic use. So the answer is, in the end, you and I are really doing pretty well. We just have to do better. The trick here is what to do about antibiotic side effects. And I had a really good lesson in antibiotic side effects as a third-year medical student. I was doing my psychiatry rotation at the VA. My psychiatry attending developed what he felt was sinusitis. So the fellow on psychiatry wrote him a prescription for amoxicillin. And the poor guy ended up in the hospital for 2 weeks with C. difficile colitis. Rule number 1, don't put your attending in the hospital. Okay? Bad idea. But for me, as a young medical student, this came in loud and clear that all of a sudden antibiotics weren't quite so benign, that there were bad things that could happen, especially now as I look back at it and thinking, yeah, maybe what we were treating in this guy was a stuffy nose. So, another question for you. According to the CDC, about how many deaths occur a year according to Clostridioides difficile infection annually? Go. Yeah, you got it. A lot, right? And of course, it's disproportionately affecting the elderly. And for those of us that are caring for a lot of young children, remember that children under 2, and many of them under 3, will test positive for C. difficile, but ignore it, right? It's part of the normal flora in young children. So if you've got a baby with abdominal pain and they test positive for C. diff, look somewhere else. Right? Don't miss the intussusception or anything icky like that. So let's talk a little bit about resistance threats here. And Dr. Lieber, kind of question for you now, right? You're working in the laboratory. What percentage of bacteria that you see or your team sees in an average day you think are now a resistance problem?
In adult hospitals, in urinary tract infections, I would hazard a guess that up to 50%. We're lucky in peds, but I will say over the last 5 or 6 years, we have many more outpatient urines in children that have ESBLs in them, for example. So it is dramatically rising, and it's a problem in terms of outpatient management when we lose the big guns and are left with no oral agents. So it can be a very big problem.
And Abby, for you, how often do you get this question? You got a patient who grows a Pseudomonas or an extended spectrum beta lactamase producing E. coli in her urine, maybe a young woman with cystitis, and you're standing there going, what the heck am I going to do?
Yeah, I know, and it's really, really a big issue. And I think the one thing that I always think about is, in a perfect world, we will all be the best antimicrobial stewards, but the reality is we have things like Press Ganey, we have patients that want to get better very quickly, but it is a real and a serious problem, and one that is actually a very urgent, and I would hazard, emergent problem.
So yeah, this is a big problem. It's certainly one of the most frequent calls I get is, I've got a kid with Pseudomonas in their urine, what can I treat them with? And as you know, oral options for Pseudomonas in adults are limited and in kids are really limited, so it's a problem. Just at a show of hands here, how many of you have had an adult patient end up in the hospital because of C. difficile? Anybody seen severe C. diff? Yeah, so I'd say at least a third of us have seen bad cases of C. difficile. So it's not a disease to trifle with. And of course, the challenge we've got now is the drugs that we're using for C. difficile are really expensive. So it's a big deal. So laboratory diagnosis has evolved. Amy, sort of take us through quickly, the evolution of this thing, how we've gone from culture to single PCRs to multiple and
Right.
syndromics?
Well, for the bacteria, they still like their culture plates. We do a lot of bacterial cultures, but viruses, I would say virtually no routine laboratory or hospital-based laboratory in the United States does viral culture anymore. And the death knell to that was SARS-CoV-2, when we were not permitted or not supposed to do viral cultures on respiratory samples. So if you want viral culture now, you have to send it to a reference laboratory. So everything has shifted from these traditional based methods to more molecular based methods. And you'll touch on the issues of sensitivity, which also go into these choices about whether to use antigen-based testing or a molecular test.
And Amy, what drove us from sort of limited PCR one at a time to multiplex?
That's a good question. Some of the first syndromic panels on the market had 15 to 20 analytes in them. And it was a simplicity of use. You don't have to understand if it's flu or COVID or RSV. You have one test, one-stop shopping. And actually, it's simpler for a throughput in testing. So really, those syndromic multiplexes took over the marketplace, and there was a gap in the middle for smaller, kind of more conscientious molecular panels, particularly for viruses. So that kind of landscape is changing, where I think there are more sensible molecular panels to run, and particularly in an outpatient setting, where you're not doing 25 targets when you only really are concerned about 5, because you can affect therapy, things like that.
Yeah. And so Amy's hit on the theme of the day, really. And that is, we all appreciate that there's these, multiplex panels. And of course, the reason behind the multiplex panel is that word syndromic, right? If you look at it, a respiratory infection looks like a respiratory infection, even though there might be 15 things causing it. Meningitis looks like meningitis, even though there might be 15 things causing it. And diarrhea looks like diarrhea, no matter how many things are causing it. So that's great. That's good in the emergency room. That may be the thing for the hospitalist. But in the day-to-day care that you and I deliver on an outpatient basis, I think Amy's right. What we're looking for is what's the sweet spot between no testing and looking for every pathogen you can possibly think of. So a couple of quick questions, and this is just really to find out what people are doing. There's no right or wrong answer here. For each of the following pathogens, are you using antigen-based testing or PCR testing? So for the first one, RSV, what are you using in your office? Are you using antigen-based testing, PCR, or you're just not sure? Go.
I'm interested in this question because we think of RSV as a pediatric pathogen, but certainly on the other end of life, it's a very important pathogen. So I'm interested.
Yeah, I agree. It's a big deal. Okay, so most people are using RSV PCR. Some people aren't quite sure, or maybe the testing's not readily available to them. Okay, good. Let's move on to the next slide. For your office again, are you using antigen or PCR-based testing for flu? Go. Okay, so it looks like PCR is rapidly becoming king here. One more question, okay? For your office, how are you testing for COVID? Go. Okay. Again, most people using PCR. That's good. And then finally, for a bacterial pathogen that we all see, what are you using for group A strep? PCR, antigen testing, or you're not quite sure? Go. So lot of people still doing antigen testing. As I say, no right or wrong answer here. It certainly has some very specific advantages. And so with that in mind, Amy, as we look at the different types of point of care testing, take us through the advantages and disadvantages of each.
Sure. So when we're talking point of care, there are some considerations we'll go through, but certainly if we think about antibody testing, I don't think that has a place to play in upper respiratory tract infections. If you detect someone has antibody to influenza, that just means they've had it in the past. So I don't really think that has a role to play. So then we're left with antigen detection and NAT, or nucleic acid amplification. And the methodologies are different. If they're used point of care, they're both going to be relatively simple to use. But then the big issue is sensitivity and specificity. So the antigen test lacks sensitivity. It does have relatively decent specificity if you're using it in flu season. So you shouldn't be using an antigen test all year long for influenza, because your pretest probability goes way down and you're going to get many more false positives. A molecular test detecting nucleic acid has the advantage of both a good sensitivity and specificity. So again, either of those choices you could use for diagnosis of upper respiratory infections at point of care. And then the other issues come into play, which we'll discuss, like cost and ease of use. But really, as we saw in the poll, it's either antigen testing or NAT.
Okay, thank you. Actually, Abby, quick question for you. In Florida, I don't know if it's our tourists or what, we have an all year round flu season. Do you have the same thing in Southern California?
Not so much, no. It sticks to, mainly sort of fall and then going into, maybe some stragglers like March and April. But I really think that that was such a good point that you brought up, Amy, the fact that we have to think about things like pre-test probability. Patients come in and they will sort of tell you what they have. I've had many patients, even last week, there was a patient saying, I know I don't have COVID. And I was like, well, how do you know that? Well, because I saw in the news that it's causing sore throat and I don't have that. So we really, want to remember that before you get a test, you have to think about, whether or not it's actually going to inform you, as accurately as possible as to what's going on, and the fact that there are false positives.
And Amy, you touched on something earlier, but I just want to reiterate it. Is there any role for culture anymore in respiratory infection diagnosis?
No, basically no. I mean, some of the bacterial pathogens like pertussis, that totally has been replaced. Group A strep, in children we used to have to back up a rapid antigen with culture, but now that's backed up with molecular. Yeah, no, not that I can think of, really.
Okay, so if you're...
Gonorrhea from a throat, maybe, but that's not really upper respiratory. But.
Yeah. Okay, so if you're making your business selling culture medium, tough. We're just not doing culture anymore. Okay, so the question is, why are we doing this? Right, what's the purpose of a rapid test? And of course, we've all got different reasons for doing it. The real reason, of course, is to minimize diagnostic uncertainty, right? We want to be able to tell the patient they've got something viral, kind of go on from there, because, well, for them, of course, the challenge we have is telling them that they've got something viral. They look at you like you just gave them the booby prize, right? You tell them it's a virus, that's not the answer they want to hear. But what it can do is guide you and me through kind of the principles of microbial stewardship and sort of go on from there. Because what it's driving us to is the right action. Now, sometimes the right action, as you know, can be no action, right? Symptomatic care, that kind of thing, supportive care to a patient. But if it's a patient who's at risk and they have COVID, we can talk about an anti-COVID drug. If they have influenza, we can talk about a neuraminidase inhibitor or one of the nuclease inhibitors, something like that. So there are therapeutic reasons to do this. And again, for those of us that are doing a lot of primary care, this often plugs you into an algorithm. Just out of curiosity, what percentage, how many people in this room have to answer now to sort of an algorithm as part of your QA at work on management of upper respiratory infections? Okay. Not very many of us. That's interesting because, Abby, tell me, what's the future on this algorithm?
Well, I mean, I think they're available, right? So a lot of the EHRs will sort of prompt you toward that pathway. But just in general, I think it might be another way that people are sort of evaluating quality of care. So it's always important to be thinking about those things.
I mean, in our system, if you deviate from the algorithm, I think you almost go to court to defend yourself.
Oh no, that sounds terrible.
Okay. All right, so let's move forward. Amy, tell me a little bit more about kind of comparing just for background here, the big multiplex panels.
So how many of you have sent away and ordered a huge multiplex for respiratory? Anybody? No? There's never a patient where you thought it was needed? Well, these exist, just so you know. All of these on this panel are usually done in a large reference laboratory. They use different methodologies, but they're all amplification-based, and they can take anywhere from 15 minutes up to 5 hours. So the one on the far right, Luminex, that is basically very high complexity in terms of testing, and it takes 5 hours, which would in no way be able to help you when your patient is in the room. Additionally, some of these take up to an hour and a half, and I often wonder, would an hour and a half turnaround time help you at all? How many think it would help? Yeah, you need it around 15, 20 minutes, I would guess, in terms of it to be useful. The other thing is the number of targets on these tests, and we'll go through that in a minute, but here they are. So most of them contain bacteria, and that can be very useful. They have pertussis, parapertussis, chlamydia, pneumoniae, and mycoplasma. So we had a huge mycoplasma outbreak last year. Did you guys feel that in your practice?
We've seen more of it.
We had thousands and thousands of patients, and really in the United States, getting a multiplex is maybe the only way you would have locally to diagnose mycoplasma. So it can be useful. Then we have all these other viruses. And the interesting thing is, do we need to know that it's para 1, 2, or 3? Probably not. But some of those panels delineate that. For influenza, you get an influenza A call, and then you get the subtype. And that can be very useful to know. For example, during the concern this summer for avian influenza, the hospitals were told to look for flu that was positive for influenza A, but no subtype. That was our marker that this might be avian influenza. So these have utility, and the fine points of what's on them can be very helpful in certain populations. But I would say overall, they may not fit in an outpatient setting very well, because probably you'd have to send it off to get the result.
Okay. Now, Amy, I've seen kids come to me too that have had a send off with other panels that they've tested positive for a nasal swab for Streptococcus pneumoniae or Haemophilus influenza. Comment?
Yes, that's normal flora in the upper respiratory tract. Now, I know it can cause ear infections and sinus infections, but it would not be an appropriate target on this multiplex panel that's done from an NP or a nasal swab.
Okay. Now, you've used a couple of terms here. You've talked about point of care testing. Distinguish again point of care versus laboratory, and a little bit about how these things are regulated, because there's another term that comes up here, which is CLIA.
Right.
What is that?
So point of care testing, as the name implies, is near to patients. So it could be in the ED, it could be in the clinic, it could be in your office. And the idea is that they should be relatively rapid to allow you to manage the patient before they leave. The laboratory has the ability to do basically any type of testing, high complexity testing that takes a lot of skill to run. The other term that gets mixed in here is wave testing. So how many of you do wave testing in your office? Virtually all of you do. You do urine dipsticks, those are waved. Right. And wave testing is a CLIA kind of certification that these tests are so simple to do and that an error is not likely to cause major harm. So you can have people that aren't really trained laboratorians run them. And so together, point of care and waved is really kind of the sweet spot for the types of tests you want to do in a physician office or close to home. What I can say is wave testing doesn't mean you can't mess it up. You definitely can mess it up. So for example, if there's 3 bands on an antigen test, people read them in reverse or they overread them. So simplicity and ease of use is in the eye of the beholder somewhat, but certainly it's designed to have a result available to you and actionable.
And I think this is just so wonderful listening to you talk about this, just because we do, I would say most of us do these tests probably every day when we're in the office. So I think the big learning point is if there are certain times when a patient is not improving the way you expect them to, or they're just not getting better. So essentially, I would just be thinking about that. What was the data point that I used to essentially evaluate this patient? And we're all used to acting on, again, positive tests, but even question that in the clinical setting where a patient's not necessarily getting better.
Okay. So Abby, you brought up a good term, which is the data you're using. So Amy, take us through quickly, what are the choices got? If people have got their offices going here, what do they likely have?
So I'm interested, how many of you have an impact on what testing is done at your office? So some of you don't have the control over it, some of you do. And I think in the next couple of years, you're going to be faced with this decision. Do we move to molecular testing? And if we do, what would it be? And I think some of these smaller kind of mini panels might foot the bill. Obviously, there are molecular tests that are waived for influenza A and B. There's a number of them. Some of them also include RSV, and then some of them would include COVID. So I think if you had a rapid molecular test in 15 to 20 minutes for flu, RSV, and COVID, I think it would be very useful. The cost is a whole set of other issues. One of these also has group A strep on it. To me, I don't know, I'm not a physician, I'm a laboratory. Those are 2 distinct entities. So I don't really think those make a whole lot of sense on one panel. But again, we're getting to the point where you don't have to order this 67 member panel. You could do something that's rapid and really gives you actionable results. So again, this will be becoming more and more a part of your decision making in the office setting.
Amy, one more question in that respect. 10, 15 years ago, PCR or nucleic amplification tests, these were pretty high tech and were never CLIA waived.
Yeah.
How many of these tests are now PCR based?
All of those but one. The Binax now is an antigen test. The others are PCR based and they're very simple to use. They're a concept called sample to answer, which means you're going to take a swab, stick it into the device, and stick the device on the instrument. You're not manipulating amplified nucleic acid. It's very simple to use. So that's why they're waived. They should be so simple that they're not prone to error.
I was talking to a pediatric resident, and I said that running these tests was as hard as putting a VCR in the VCR player, and he looked at me. What's a VCR?
Oh.
So yeah, it turns out it's CDs aren't even there anymore, so you can't say that. So I don't know what to tell people. But anyway, all right. So let's look at this then a little bit further. Tell us a little bit about test complexity and how this sort of moves forward. And if you want to advance as you
Oh, sure.
slide.
So we talked about wave testing. That's probably what most of you are doing. High complexity has to be done in a laboratory. It's regulated. You cannot do that. It has to be done by trained technologists. Moderate complexity, some physician office groups have a moderate complexity laboratory that has trained personnel. But if I was to guess what most family practice people do, it's mainly wave testing unless you're in a big practice. We talked about that diversity from antigen testing to nucleic acid. We want to err on the side of sensitivity. Interestingly, in 2017, the FDA reclassified influenza antigen testing to make that it had to reach a certain standard, and it has to be 80% as sensitive as PCR. And so a lot of the antigen tests on the market for flu went away. So pretty soon you're going to be forced to do nucleic acid amplification. We talked about the number and types of targets that are necessary. How do you?
Blue, or the green one.
Oh, the cost. Cost is a major issue. Even these waived molecular tests are going to be pretty expensive. And that's a decision to make. Antigen testing is relatively cheap. The issue is its lack of sensitivity. We have reimbursement. The full multiplex tests are often not covered by insurance, and then your patient gets this bill back, and they're very upset. But in our community, the richer pediatrician offices, their patients want this full-fledged molecular testing. So it can range anywhere for it's not covered at all or partially covered. So again, you'd want to consider that. Impact on workflow. Right now in many of these molecular tests, you take one sample and put it in one machine and it runs for an hour. In respiratory season, you'll never make it through your office day because your testing will get backed up. So again, it has to be relatively rapid, easy to use, and good throughput. And then finally, obviously, and you two can speak to this, the clinical impact. I don't know if you want to comment on what you are looking for when you get one of these respiratory tests in terms of the impact it would have.
Well, I mean, the first thing is always, and I think, again, this has really taught me to, first of all, think about their symptoms, think about what, season we're in and all of that, just because testing, especially, these less sensitive tests can really lead you down the wrong path. But again, patients love to see positive and negative tests. That's sort of, it's sort of like, I guess the lawyers will say all the crime shows have made our lives more difficult because people want to see evidence of things happening, all the time. And it's really, just something that patients are reassured by if things are negative or positive. So I think it's really just important to still explain that, well, this is why we're treating you this way for this reason. It could still mean that you may not have it, or that, it's there and we, aren't picking it up. So that's really how I would say it would affect things.
Okay. All right, let's roll on to some of the cases. And here, again, we're gonna try and move to a bit more of a discussion. I'm going to ask Amy and Abby to sort of move down into the audience and sort of pick some tables, but we'd like you to have some discussion about this with your dining colleagues for a few minutes. Amy, why don't you run us through this case, and then we'll launch into some discussion.
Okay. So here we have an 8-year-old male with standard risk ALL. He's currently receiving maintenance chemotherapy. It's November, and his class has several kids with upper respiratory infections. So again, he's a relatively stable, immunocompromised young child in the community with 1 day of fever, cough, and rhinorrhea, decreased appetite. Key to this is he's not neutropenic. Obviously, if he had fever and neutropenia, he would probably go to the ED right away or to his oncologist. So he's on physical exam, he appears mildly ill, clear lung fields, and no focal findings. So how would you approach diagnostic testing in this patient and also other immunocompromised patients? So you could see someone on an immunomodulator, they're not going through chemotherapy, but how do you think about diagnosing URIs in these patients?
Okay, so let's give you a minute to have some discussion here, and then we'll sort of poll around the audience for answers. So 8-year-old, November, oncology kids, so a somewhat increased risk, immunosuppression. What do you want to do with him now that he's shown up in your audience? So we'll give you a minute or two to discuss amongst yourselves. We'll go from there.
Hi. Here, you can go. Hi. Hi. What do you guys think? Are you guys all family? Are you all family? Oh, okay. Oh, great. Oh, nice. Have you had scenarios?
Okay. Time for your 15 seconds of fame. Amy, what's that table got to say?
I have someone here. Tell us what you said. It was very insightful.
Well, the first question is, do we test or not test? And he's in a community of something that sounds
Do you guys have
in his classroom, fairly benign, and with known symptoms. And so if he can match that, then maybe you're going to monitor him and treat him symptomatically.
Yeah.
So I don't, absolutely. Does the fact that he's on chemotherapy give you any pause in terms of just wait and watch? Or would you want to give him oseltamivir if there's flu circulating? Any thoughts on that?
Those are good things to raise, and I hand that off to other people.
Okay.
Anybody else with a comment?
Abby, where are you?
I'm here?
Okay.
In my clinic, I have one that checks doesn't check for one, checks for COVID, checks for flu, checks flu RSV, and
Yes.
it checks for flu A and B.
Yes.
So, I mean, I can't just choose one.
No, right. And that makes sense too, because you can't tell them apart, and there's treatment for both influenza and COVID. So to me, that makes sense, right? Yeah.
Abby, anything from your group?
So someone is actually saying that you only have,
Anybody else?
a lot of people have only one of these tests available, so not
Say
necessarily a lot of these different tests. So that's something to think about as well.
All right, so let's check in on the polling question. Go ahead and vote here on what you do. Again, no wrong answer. And of course, it's going to depend on what the kid looks like, but let's just see what people have to say.
You can say something while they're waiting. Go ahead.
I think it's rare to have. You said what?
Okay.
Yeah.
And I think these are all very reasonable answers. And in fact, another very reasonable answer is do nothing and watch the kid, right? But I think one of the things you might want to consider, especially if the kid's had some T-cell immunosuppression, is this might be a candidate for a neuraminidase inhibitor, some oseltamivir or something like that.
We have a comment back here.
Yeah.
I was just going to say, I agree with testing for flu, but I'm not really sure how testing for COVID or RSV, other than giving the parents a clear diagnosis, I don't see how that would change management, because we don't have antivirals that will treat that in an 8-year-old, to my knowledge.
Right.
So, I mean, aside from watching the kid closely, which hopefully you would be doing anyway, I don't really see the value in testing for those 2 other conditions.
Yeah. Yeah, I think you're right. And as people have pointed out, you may not have the choice. That's the 3-test panel you've got. But yeah, I think that influenza is the one that you and I are most worried about here. So again, just a little bit of discussion here. When do you send this kid to the ED? Well, I think that's a pretty straightforward question, right? If he's short of breath, if the parents are anxious, if the oncologist is anxious, then it's an ED trip, and it may be a larger panel, and we'll go from there. Some quick considerations here now, just talking as an infectious disease perspective. Again, these kids have T-cell dysfunction, so they are at risk for severe influenza. This would be a kid where you'd certainly consider treating with oseltamivir because they are at risk for more severe disease. All right, let's continue on with the case. Amy, you want to go ahead and read that from here?
Sure. So In this situation, the clinician ordered a rapid molecular five pathogen panel. It was positive for flu A. So he was treated with the antiviral. They gave him additional advice on isolation precautions and supportive care with close monitoring. And again, this clinician then felt comfortable not prescribing antibiotics. So an additional question is, does detection of influenza in this patient eliminate a concern for a bacterial pathogen or sepsis?
So what do you think? Never makes it go away, does it? Right? Everybody's worried about sepsis. I think the answer is that it depends on how the kid looks in front of you. It's well established there's an association between pneumococcal infection following influenza, especially influenza A. But I think in the short term, if you've got a positive test for influenza, that probably is all the explanation you need for this child right now. Okay, moving ahead. If the mini panel were negative, you didn't get anything, what do you want to do with this kid? Go ahead and talk with each other, see what you think.
Well, maybe that's what you ordered.
Would you order it?
I know. I thought this was a really good, I think this is a really good.
All right, Abby, what you hearing over there?
I heard something really, really great. You brought up a really good point. Do you remember what you said?
You probably have to collect those.
Yeah. Did someone say a false negative? That's a good point, right? It could be a false negative. And so I think that's a really good point.
Okay.
And so you should always question the test and don't assume that it's, always the 100% accurate right answer.
Okay, so that's a really good point. What's the risk of a false negative? Amy, put me in the ballpark for these rapid antigen tests, especially or not the rapid antigen tests, but the PCRs and the controls that go into it. What is the false negative rate? Any idea?
It's relatively low. I think if you had an antigen test, I would be very concerned about a false negative. Depending on the season, the data supports that in adults, the sensitivity can range from like 10% up to 90%. So it depends on the circulating strain. And as you know, in adults, you have lower viral loads in your nose than children. So, but in a molecular test, I don't see a lot of utility in ordering a second molecular test as long as you understand the performance of the one you're using. They're all going to be in the mid-90s probably.
Okay, so I think that's a really important point. It depends on the test you're using. If it's an antigen-based test, yeah, you and I are going to be really concerned about the possibility of a false negative. If it's a PCR-based test, then less likely so. And in fact, the challenge we've had, right, with COVID is the kids keep testing positive for weeks and weeks afterwards, and then we're standing there going, what should we do about it? Okay, let's move on to the next case. Abby, why don't you go ahead and present this one?
Okay, so for this case, it's an adult patient, so a 65-year-old woman with a history of COPD, so that's their risk factor in addition to their age. And they're coming in with a 3-day history of fever, headache, myalgia. They have moderate symptoms. They just came back from a visit with their family, and they met their newest grandchild. In terms of their physical exam, lungs are clear, oxygen saturation's normal, 97%, talking in full sentences. And so how would you approach diagnostic testing in this patient?
Okay, and I want to throw this question out in two ways. How are you going to approach, what's your differential diagnosis? And secondly, what are you going to do if the patient's not been vaccinated against flu and RSV? And what are you going to do if grandma has been vaccinated against flu and RSV? So go, talk about it for a minute, and let's come up with a plan for this kid.
Lady?
I love this. I love this. Okay.
Okay, so based on your study, your discussion, what test are you going to do for this adult, if any?
This was a great discussion.
Well, this is a great discussion because it's an adult, 65 years old. So we are concerned about COVID, we are concerned about RSV, but also flu. So for us, we would like to do a test, a rapid test, just to make sure that we can make a decision quickly, because this is a patient with a high risk of complications for this, if have any of this virus positive.
Yeah.
That was really great. That was
Yeah.
awesome.
Okay.
How about the possible clue about the grandchild? Anything about that? I think someone here mentioned that. Someone say something?
Amy, any discussion from your end?
Anybody want to take on the grandchild? RSV, we're concerned about RSV.
Yeah. Of course, two things we're worried about with grandchildren, right? RSV, and one of the big predictors of resistant pneumococci in adults are your boogie little grandchildren, right? So we've got to think about that as part
Someone
of the
said
deal here.
pertussis also.
Yeah, good thought, especially if they're exposed to teenagers, right? Pertussis. All right, Abby, update us on the case here.
All right. So essentially, we heard everyone talk about flu, COVID.
I'm sorry.
all of
Let's
those.
let people fill this out. I'm sorry, real quick. Everybody, pull their question in. I'm sorry.
All right.
Yeah. Go ahead.
Yeah, that's great. Yeah, so everyone picked essentially all of the above because that's, of course, the most helpful. So that's really, really great. And so this goes into really something that we do every day, especially this time of year during the fall, which is who should we be testing and what should we be testing them for? And of course, COVID, first thing that comes to mind, especially at a time when it's circulating like this, and risk factors for severe illness, which you brought up, and that was a really great point. But also people that have close contacts with individuals that are immunocompromised or otherwise vulnerable to infection. So going back to that previous question about what's the point of testing if we can't treat, specifically with an antiviral, this is one of the reasons why you may want to test. Of course, hospitalized patients, we typically would test in that case. And then asymptomatic testing, which was something that we weren't necessarily doing at the start of the pandemic because a lot of people were symptomatic, but there are some cases in which you would test asymptomatic individuals. And essentially, again, when it comes to those infection prevention measures, for example, at a skilled nursing facility where there are a lot of people that may be vulnerable, and then in someone who is at high risk, maybe they've been exposed potentially, and you want to just be watchful. So a lot of times you may have a patient that you're treating, for example, and their wife who is in their 60s is saying, well, how about me? Should I be worried? That's a common question that we get. So those are the cases in which you would want to test for COVID. And then flu, also similar, essentially when you are thinking about, again, like with COVID, the decision whether to treat with an antiviral or antimicrobial therapy when you're trying to decide, is it viral, is it not viral? And again, similarly, high-risk contacts, infection control measures, public health measures, and you don't want to, of course, think that people might be vaccinated and so I don't need to test them. Of course, that should be obvious to most people. And especially in flu, we do treat with antivirals even when we don't necessarily have a positive test result because that you don't want to delay treatment in someone that you have a high suspicion for being exposed. Again, a common question that we may get. People will say, well, this person tested positive, I live with them, I'm taking care of them. So that's also another consideration. And again, we talked about pre-test probability when influenza virus is circulating. We're going into actually already in flu season. So people that are immunocompromised, high risk for complications presenting with influenza-like illness. Of course, if someone has pneumonia and you're wondering why this person has a chest X-ray that shows this, have I tested for flu? You want to keep that in mind. And then a lot of times when you see people that have exacerbated chronic conditions like asthma, COPD, these are people that are high risk. Their heart failure is exacerbated. We know flu does this, and so it's important to think about that. I don't know how many people here actually practice in a hospital setting, but we know, of course, those patients are going to get tested for essentially everything. And then, when it's not circulating, so what that long line is saying is essentially what we've talked about, which is, you probably shouldn't be testing most people when it's not circulating because, again, you could run into having false positives. And so in that time, you should think about not testing unless there's a specific public health need for that. And then RSV, that's a bit of a complicated one. Most of us don't have ready access to RSV testing, but in immunocompetent adults, if identification will affect your clinical management, a lot of times that's really just because you're trying to rule out other things, or if you've tested for flu and COVID, those are negative, you're still trying to decide what this person has going on. And it's more important in people that are immunocompromised, so in people that are transplant recipients, just because you may now start to think about treating them with an antiviral. But again, a lot of times that happens in the hospital setting. But those are things to be considering when it comes to testing just in general for these viruses.
Okay. Good. Couple of remote questions come in. And again, no wrong answers here. But in the midst of flu season, if you've got a patient who is symptomatic of what is an influenza-like illness, are you generally comfortable just saying, let's start oseltamivir without a point-of-care test? How do people feel about that? Yeah? Okay with that? Yeah, I think most people are okay with that. The drugs are very safe, right? And it's a reasonable thing to do. Now, what about if you're worried about influenza? Patient's got a cough, starting antibiotics empirically early on, worried about infection. Any thoughts there? That's a harder one, right? I think most people would steer away from that, but I think again it depends on how the patient looks. But that might be the guy that you send off for a chest X-ray and go on from there. All right, Abby, finish this one out. What you got?
So essentially, we had that available, if we're lucky enough to have it available, a rapid 5-pathogen panel, which was positive for RSV, negative for flu and other viruses. So, of course, this helps you to rule out other viruses, and which is important because if they were positive for flu and COVID, that would absolutely influence your management. Someone who's high risk, you would offer them an antiviral. They have moderate symptoms. So this is, of course, very helpful just in general. But the point of the testing, well, one of the points of the testing is just giving you confidence in your treatment plan, just in general. So hopefully that does help to inform that in general.
And Abby, question, an adult with COPD, 65, you diagnosed with RSV, what's the likelihood of them having a COPD exacerbation as a consequence?
Pretty high.
Okay.
Pretty high.
Any changes in management going to be brought on because of that?
Well, just in general, I think really based on how they're presenting. So with this patient, their oxygen saturation was normal. They're sitting there talking to you, whether or not they have support at home if they get worse. So all of these things are things that could potentially influence that.
Okay. So kind of from the group then, it sounds to me, if I'm hearing everybody correctly, that most of the time you don't have a lot of control over the testing that's available to you. We've got either a single antigen test, you've got a 3-panel PCR test. I guess the quick question I'll ask everybody is, when do you push for something larger? When do you decide somebody needs to go to the ED for a bigger panel test, or you use a 5-panel or something like that? So quick discussion. Amy, what are you hearing over there?
Anybody? Comments? I think these family practice are confident in their choices. They don't need
Good.
a big panel.
Good. Yeah, I don't think anybody needs anything really fancy at this point.
Yeah, absolutely.
Yeah.
Let's ask. That's a really good question.
Comment there, Abby?
So yeah, you had a question about an earlier case, right?
Yeah.
Oh, I was just wondering what everybody thought for that first case with the 8-year-old who has obviously a immunocompromised condition, like, and your rapid testing is negative, and he's still febrile. Like, when is it appropriate to do an ASO titer?
I think that might be a good question for Amy. What do you think about that?
An ASO titer? These smaller panels usually don't have group A strep on them, so I would definitely start with a conventional antigen-based or culture-based test for group A strep. But in my setting, in a pediatric hospital, if they had gone to clinic, they would have then ordered the larger panel, because something like adenovirus can be very devastating in these children. So I was kind of shocked that nobody would go for the bigger panel, but again, I practice in a different setting, so.
Yeah, and ASO titer, people have used them a lot over the years. I think most of the evidence now says unless you're thinking about rheumatic fever, don't mess with it, because it lacks specificity, and I get sent a lot of those, and it's a headache. So, good. Well, we're getting a lot of interesting questions sort of about empirical use for Tamiflu. You're kind of quickly, even without point-of-care testing results. So I think that's an important issue that we can discuss a little bit later, is the value of empirical treatment with Tamiflu. So let's move on to a third case. I'm going to present this one. 17-year-old black male with a BMI greater than 30, brought in by his grandmother, who is his primary caregiver. He's had a runny nose for a couple of days, cough, fatigue, his appetite's down, low-grade fever. Grandmother also has some symptoms. She's been sick for about 3 days. She's got a history of some chronic lung disease. Maybe she was a smoker. On exam, the kid has some mild respiratory distress. He's tachycardic and wheezing, moderately ill-appearing. He's kind of worrisome. So what do you want to do for this kid? So give me a testing strategy. Go ahead. Yeah, I like this, and I like the fact that you're looking for COVID. Remember the old adage that not all that wheezes is asthma. And this is something I see from time to time. This is a kid with some myocarditis due to his COVID, right? He's got risk factors because of his high BMI, because of his race, because of his age. And so this is definitely a kid who needs a COVID diagnosis if he's got it, because this is a child where we might be calling the cardiologist to say, well, can we manage this kid as an outpatient? Does he need to go to cardiology clinic this afternoon? Does he need to go to the emergency room? Is this a kid where we would consider admitting him to put him on remdesivir? There's all sorts of interesting issues around this young man.
And there was a point that you brought up. You said that RSV may not be as helpful.
Yeah, I mean, given the 4 choices, I would choose number 2. But if I were in my own office, I would first test for COVID. And if that were negative, then I would test for the flu.
Yeah.
And I would leave it there.
Yeah, yeah. And I don't know enough about the economics. Amy, testing for one and then another 2 separate tests versus one lumped together?
Well, it kind of depends on what's at your disposal. Obviously, to run 2 antigen tests, it's probably still cheaper than a molecular test, but maybe not as good. But nowadays, more and more tests are being built to be multi-pathogen detections to make it simpler and cheaper. So,
Okay. All right, so we'll roll on here. I'm sorry, go ahead, Abby.
Did you have a question?
Just a comment there, because I think to cover further what insurers cover in your area is a big deal. And because I see a very broad population, a lot of multi-panel tests are not covered. In fact, CLIA wave tests in my office often aren't covered. So I would vastly prefer the rapid antigen test that rules out, I'll have to send the PCR if the antigen is negative, obviously. But I think that's the sort of thing that we really need to hear about, because that's the part of the decision making for me. And unfortunately, too many insurance companies aren't covering these tests in the office.
And can I just say something, Ken, real quick? Oh,
yeah.
Sorry. For the large order multiplex tests, they have a special code, a CPT code, which is a proprietary code. And if you bill for a multiplex respiratory panel on a given date of service, so many other codes are disallowed. So for example, if you had a kid come into the ED, and they did a rapid multiplex respiratory panel, and he was that HEMONC kid, if you ordered a CMV viral load on that same day, it wouldn't be paid for. So you're absolutely correct. You need to understand the CPT codes and coverage in your area, because it all plays into that decision of what you bring into your office. Definitely.
Okay. Other comments there, Abby? Okay. So let's move on here then. Again, Amy, what's the process here? How do decisions get made at a system level versus an office level? Abby, comment as well here too. How do people decide what test is available?
Well, at our institution, again, this is done by committee. Obviously, we have a range of testing, but as I said, we still use influenza antigen testing in our clinics. And even though it lacks sensitivity in children, it still has pretty good sensitivity. But we will not allow our outpatient clinics to bring in whatever they want because of the cost of that as a whole. And I think in your case, and in a private practice, you have to be pragmatic, meaning you may want that 3 multiplex PCR panel, but it's not reimbursed, or it's just too expensive. So I think there's so many things that go into this decision. Your hand is going to be forced a little bit in that I think more and more the antigen testing is going to go away. So you'll be left with a costly choice to switch to molecular, really, probably. Okay. Anybody else have a comment?
Well, I have an interesting show of hands question. How many people work as part of a larger healthcare system? Okay. And how many people are private practice, like their self-owned practice? Okay, so that's probably part of, I'm guessing, what may influence some of this. A lot of times, those of us that are part of a large healthcare system, these decisions have already been made for us, and what's available is what we have. So I think that's one of the aspects of this to consider.
Okay. All right, let's move on here. So, yes, we got a test back. The kid tests positive for COVID, negative for other pathogens. An EKG probably be a really good idea to look to see if this kid's got any evidence of myocardial inflammation. Maybe a call to the cardiologist, maybe a call to the emergency room. But I think that's our management decision in this kid. When we see COVID, it's lifting the lid on a whole bunch of other problems. And of course, the characteristics you and I are looking at are epidemiologic factors that this kid's at risk based on body habitus, race, and age for COVID-related myocarditis. So some clinical considerations, again, is myocarditis. RSV we're worried about because of transmission to his grandmother. Again, she's also got lung disease. Multiple people at home. So now we're going to try and tie all this together for some microbial stewardship in the last 15 minutes or so as we go forward. So microbial stewardship, right? It's a complicated process where we're sort of telling us to sort of loop around here where we're starting with the patient. The first thing about microbial stewardship is it requires the best diagnostic stewardship that we can have so that we've got an idea of what we're dealing with, and that will help us guide antimicrobial therapy. That will also guide testing, and that's where Amy and her colleagues come in with the laboratory. And then once we've got data from the laboratory, guiding antibiotic selection and going from there. So, Amy, I want you to kind of comment a little bit on this slide on what you see as a microbiologist on the different segments of microbial stewardship.
And this is kind of a circle of trust in terms of kind of a larger healthcare setting, but hopefully in your community you have contact with microbiologists. We're really great people. We can provide you with regional data on the types of viruses that are circulating and give you advice on what type of testing you should have in your lab. And often it comes down to the choices in terms of financial issues, in terms of within our system. Obviously, we can't pick exactly what we want always. We have to make compromises with hospital administration in terms of financial and connectivity issues with these boxes. They're not all designed to be fed into our EMR. And ultimately, we do listen to the end user. So, example, in our ED, we have rapid point of care tests that allow them to get the pace of the ED through for things like, in our ED, they have flu, they have COVID, and they have RSV that are available point of care, again, designed to kind of manage that patient throughput that is so important. But if I leave you with one thing today, it's that the microbiologist is your friend, and in your community hospitals, they're going to know a lot about the viruses that are circulating when RSV season starts, so you know when you're supposed to start those types of therapies. So again, it's a working together to get the best stewardship.
Okay. Yeah, and speaking of that, and I'll put my pitch in as a pediatrician, how many of you are regularly now advocating RSV vaccine for your elderly patients? Yep. So I've had mine. It's a great vaccine, and you know, it's a very reassuring thing. So, question for the two of you, and especially for you, Abby, because one of the things you think about in your quality world is cost effectiveness. What goes into the decision-making process as you look at your enterprise and quality in terms of which testing to pick and what to make available?
Well, I think, you know, to the points that we've already brought up, cost, because that's a big factor. People don't want to get bills that they weren't expecting. Insurance coverage, that's a big part of this. And then really, I want to test that. I want the most rapid test that's the most accurate test, but also the most rapid test. And sometimes those things, you know, go against each other. But essentially, you know, something that at least gives you enough confidence to be able to proceed with a plan. That's really, you know, what we want. Things that are simple to use, because we're not necessarily the ones doing the tests. A lot of times it's our assistants that are doing the tests. So those are things that are important to consider.
Okay.
And I will just say, if you are limiting your testing to influenza and COVID, I think the data would support those are the most effective results you can have in terms of managing your patient. If you look at the literature, there's much less data to show having a call out for rhinovirus or human metapneumovirus really impacts how you handle the patient, both inpatient and outpatient. So again, in the sense I get in the room is you're doing influenza and COVID, and probably that's an okay place to be, really.
Okay. Good. All right. So a couple of quick questions, and we'll wind things up here. Abby, in an office, what do you have to do to accommodate for this kind of testing? What do you advise?
Well, essentially just thinking about efficiency, which again, we're all working against time. And I always say that I'm proud to be a family physician because I have to know everything about everything and be able to handle whatever walks into the office. So really efficiencies, wherever you can create those. If you're using an EHR, trying to have things like order sets that can make things more efficient, even having people, the phrase is work at the top of their license, be able to order tests ahead of time, anything that essentially makes things more efficient for you.
Okay. Amy, for you, kind of the next two questions, I want to
Yes.
lump them together.
Yes.
One, what's involved in training people for a CLIA waived study? How do you assess their competency? What do you do? And then what's the QI process?
Yeah, so I think many of you have no idea how this training is done, do you? And it's not probably done to the highest of standards because what we see is a trainer, someone will get trained and then they'll train the next person. And about 5 people down the road, no one knows what's really in the package insert. So when you train people, you should train them to the package insert. That may sound like a small deal, but it's not. So while they're meant to be so simple anyone can use them, that really isn't the case. 2 minutes means 2 minutes. It doesn't mean start the test and go do something else. There's a lot that goes into doing it well. And in terms of quality assurance in your lab or in your office, if every test you do for flu is positive, there's something wrong, right? You need to track some kind of metric, like the positivity rate per week or whatever. For example, for molecular tests, you can detect if it's a live vaccine, you can have contamination with influenza vaccine that shows up as a positive test. So just my guidance to you is it's not necessarily as simple as it seems, and a little oversight will go a long way.
Okay. And what about the QI side? What's involved there?
Technically, there is no real QI involved. You have to do your controls and mark them down, but CLIA waived is pretty light in terms of oversight and QA.
And Abby, you sort of mentioned pathways. Is this a good maintenance of certification type activity for physicians?
I think so, because it gets you thinking about testing. At least it got me thinking about testing in a different way. A lot of us don't necessarily stop to think about what, and in fact, we were talking about the EHR, just has 2 tests for COVID or just 1 test for COVID. What is that test exactly is not necessarily always spelled out, so it's important to know that. Is it an antigen test? Is it a PCR test? Those things are helpful in terms of management. And, in the scenarios where it can be, the most impactful, we know that we have, the quote unquote triple-demic, where you have a lot of viruses that are circulating at the same time. We can expect that over the next few years. So you are treating different things differently. And it does impact your management decision to know if someone has flu versus COVID, for example. And again, that's sort of new because we didn't have, necessarily antivirals for COVID as well. And so all of those things are, things to think about. People that are immunocompromised, maybe people on chemotherapy or that are neutropenic, these are, things that are going to be important to know in terms of the specificity of which virus, you're dealing with or which specific infection. So these are all different scenarios in which this can be helpful.
All right. So kind of 2 questions to wind things up. And I'll direct this primarily at Abby. What clinical scenarios do you think these tests have made the biggest difference?
So, and, so like I was saying, in people that are, immunocompromised patients that may be neutropenic, on chemotherapy, those are, I think that they are very helpful in that regard. Pediatric patients, there's applicability in every scenario. Being as specific as possible is always going to be helpful. We know there are limitations just in general. The hope is that the testing evolves to where it's cheaper and more readily available and faster. But there are a lot of different scenarios in which these can be applied to.
Okay, good. Key takeaways. What would you want people to take home?
So really, I think for me, the biggest thing is antimicrobial stewardship. We know that that's really, really extremely important. I didn't realize, the amount of antibiotic prescriptions, that are out there and that we give. For example, a lot of us work in a lot of different settings. So a lot of people work in the urgent care, some people work in virtual urgent care, and we've actually, done surveys to see how many people are prescribing these antibiotics, what types of things influence that. And whenever there's a test available, that's really something that is very reassuring for people and for patients especially. So that's important. And then really just thinking again about the testing. Before you order any test, first of all, think about how this test is going to influence your management and thinking about, again, the various tests that are available. Sometimes they could be falsely negative, sometimes even falsely positive. So I would say that those are the big takeaways from this.
Amy, what do you want people to take away?
That I do think laboratory testing has a role to play. And that I would caution you to consider using the larger order multiplex in a patient that is more complicated, comorbidities, immunocompromised. I think it has a role to play, but in your day-to-day care during the respiratory season, I think that flu, COVID, and RSV are your main things you want to really test for.
Okay. And I've come away, this is a very sophisticated audience. So I'm actually quite happy with what I'm seeing and hearing. So let's wind this up, right? So again, rapid molecular diagnosis now, it's really almost all PCR. Antigen testing is becoming increasingly rare, but it's now to the point that we are doing PCR in the office setting. We can identify viruses. I think you're all asking the right question is, as long as we identify a virus, then the next question better be, so what? So we've got to decide what to do when we've got the result. But there is, I think, compelling evidence now that these tests can be used to optimize antibiotic selection. So let's wind this up, see where we did, see if we've moved the needle at all with anybody. How confident are you now that we're applying principles of microbial stewardship when managing upper respiratory infections in the office setting? From 1 not confident to 5 very confident. Go. Where's the music?
Yeah.
Okay, and so we'll wind it up there. I want to thank you all for attending today. Be sure and scan this for the QR code. Get your credit for attending. I'm grateful for you all being here, and thank you all for participating. And please enjoy the rest of your meeting. Thank you all very much.